phase 3, again, I'm going to tag with Ashley on this. I have nothing to disclose. So we're going to discuss longitudinal care management, episodic care management, office hours access, and post-visit data review. PFAC will be discussed in detail at a later session. So in phase 3, again, understanding workflow, people, process, technology, care team roles, longitudinal care management, care plan basics, in episodic and transitional care management in phase 3, which is care after the visit. The patient has left the doctor's office. So please respond to the pre-survey questions, 18 through 22. Let me pause there for a few seconds. And as a reminder for us, and this is our test patient again, Ms. Anexa, and for LCM and ECM, these are the key process steps we will touch on, and I will do this in more detail in upcoming slides. The first thing would be to manage referrals as soon as the patient completes the consult. And you need to ensure the referral management for the attributed patients seeking care from high volume, high cost specialists, as well as ED and hospitals. So we need to know where do our patients go to the most and start there. Hopefully in time, you're going to be able to identify all the players or all the providers that touch your patient, but at least you can start with those who have more high volume or more frequent encounters with your patient. And then the patient could be referred for any one of these. For care management, longitudinal care management, to a community health worker to address social needs, the pharmacist, social worker, the behavioral health specialist, health coach, provider specialist. And through it all, you just want to make sure that the patient experience is captured here. So the lead RN, this is for her the bottom line. So being supported by all the care coordinators. She wants to make sure that experiences that the patient had, in this case, Mr. Necker will be my care manager, calls me every week to see how well I'm doing and educates me on how to better manage my illness. The doctor's office called me to know how I was doing after my ED visit. My care manager helped me confirm which medications I should take or stop taking. My care manager also helped me coordinate my referrals and follow-up and helped me with scheduling visit with my specialist. So it's a balance between LCM and ECM. We talked about having that patient who's here, but they could still have an episode of care and you can adjust acuity. So think about it, that the patient is constantly in this motion. Now, some of them may move from high risk to medium or low risk, but some of them who are already in complex risk here may not because of the nature of their diagnosis, like dementia. So this is another document that is in your folder. So if you look at the FLORSIC care management workflow, again, this is just a sample just to put it in context for you. I think what I want you to walk away with here is the different players, the different staff. This is kind of color-coded so you know which one is from the practice versus which one is from the CTO. Having this as a clear picture helps give you an idea of how you guys can work well together, who's doing what the handoffs are. So you can see the primary care provider here, the panel manager, QI specialist. Again, different roles are called different things. It depends on what they're actually doing. You have the lead care manager, RN, from the CTO, and then you have a support care manager from the practice. So when you have to do, come up with a workflow for LCM, ECM, and by that I mean longitudinal care management and episodic care management, it's important to understand what the input is. So you can actually have the primary care provider refer the patient for care management because they just saw them, they think they need that. It could actually be the lead care manager looking at the attribution list and from there identifying patients that need to be outreached and therefore assessed. It could also be for some who have a panel manager or quality improvement specialist who's looking at the CRISP list and then reviewing, triaging, and then referring to the lead care manager for either patient outreach or to start a patient assessment. These are different options that I want to put out here. So there's no, again, wrong or right, but they're just good ways and better ways to do it. So something to consider. But regardless of how they get to the lead care manager's attention or referred to her or him, they have to conduct that patient assessment. Now, questions you want to ask here in red, you can see is, what assessment tool are we currently using? Do we have a care management assessment tool? Is it embedded in the EMR? And does it need to be modified? So after the assessment, the decision point for the lead care manager is, does the patient have care management needs? If no, document the decision. And if yes, then the care manager needs to determine what the disposition is. Is it an LCM for high complex risk? Is it an episodic care management or for high risk or medium or low risk, or just a care management follow-up for medium or low risk? And depending on what that is, if the patient is high risk, again, this is the lead care manager, they have to take that on. The lead care manager should not hand off the high or complex need patients, because that's where her skill set is really, really needed. So she can, or he can, initiate appropriate care management services and reevaluate the caseload as needed and continue to reassess what the needs are to adjust the acuity. Now, questions in mind is, are there any guidelines provided for longitudinal care management? In coming slides, we'll show you the AAFP tool for managing diabetic patients. What are the guidelines for providing ECM, if you have those? And what are the guidelines to follow up with patients that no longer require LCM, if at all you change their risk here? Now, if the patient, so as the care management assessment tool also has questions about social needs. So does the patient have social needs? And if yes, refer the patient to resources. If it's just a simple here, the patient is with a caregiver, for example, and there are medium or low, or they are medium or low risk, you can just have a list of resources that they can go and outreach, or you refer the patients to a support care manager to now take that on, and they can initiate appropriate care management support services and coordinate with the CHW. So now this is one example in a case where you have only 4 players. You can have another workflow that looks like this, and I'll just call out or point out the difference. So here, what we have here is that we also have a front office staff here who might be helping with scheduling or making calls. We have some practices that use the support of a vendor with automated calling for the initial episodic care list, and then they triage, and then they send the triage list to the team to now start executing. I can give you more details about that if you want to know. But again, this is another complex, sample of workflow showing more players. Again, trying to understand the handoffs. So this may be your workflow that you started off with, say in January. It can mature to become this, or it could become this, and you feel that this is a simpler way to do it. But regardless, it's nice to kind of see a snapshot of how these handoffs happen and who's responsible for what. So when you have the meeting as a practice with your CTO, and the CTO is supposed to be responsible for here, and this is where you have the most issues. You don't know how many, for example, you don't know the percentage of your patients who are high risk who have started longitudinal care management. That's something they should be able to tell you. How many people have they been able to outreach, and what is being done, or how many of them have a care plan in place? So if they fall short, when you meet during your monthly meetings, these are conversations you can have. Also, as a practice, you also have your role to play. So if your support care manager, who's supposed to be supporting the lead care manager, is initiating care management services for medium and low risk patients, that support care manager should be able to provide the same information, right? So it takes a village, but everybody needs to do what they're accountable for. So moving along, and for longitudinal care management, just a quick overview. You identify the patient, you outreach, you assess, you have a care plan in place, then you start the implementing the care plan, working on interventions for the patient, and then you analyze it and monitor over time. And you can do that evaluation also using dashboard reports, whatever you have. Again, this is a high-level process for LCM. You screen, you assess, you plan. It's pretty much a graphical representation of what I just said. Some people are more visual, so if you can have this up and the staff and people just look at it, may just kind of sink in more than if I just have a bunch of words to read. So something to consider. I would have actually come up a bit to tell you how she supports the lead RN with LCM outreach and some of these steps. Let me pause actually now and do that now so that way when it comes to identification and outreach enrollment before assessment, you kind of know how you can leverage the resources you have to maximize the time of the RN, because again, back to that 1 to 2,000 ratio was a practical example of how she can be best supported. Ashley.
So for our practice, again, we have two different practices, very small, one very large. Currently, our lead care manager manages both of them. Fortunately enough for us, we have started to use the automatic phone calls to hit the episodic care patients. So those are folks who are being discharged from the ER or inpatient, and they are meeting those goals of 2 days if they were discharged from inpatient, and then 7 days if they are being discharged from the ER. And so they get automatic phone calls. We were able to customize the message. So on a caller ID, it says doctor's office from a local number. It says this is your care team from Dr. X, Y, and Z, just calling to follow up. Press 1 if this is you, press 2 if this is not a good time. So it's very comprehensive. A lot of work went into customizing that message to make sure we reach the maximum amount of patients. For our bigger unit, though, we are calling still because there's some issues with CRISP and getting the right list and all of that. But we call them every morning, any discharged patients, and we try to make sure that we are compliant with the 7-day, 2-day notice. So that's really been helpful to have that automatic system kind of help lessen the load for our RN, our lead care manager. For the long-term care management piece, we try to do 1 phone call from the nurse and then 2 additional phone calls within a day from the CHWs. If we do not reach the patients, we literally this week we've been looking at what the next step would be, and I found that making phone calls from the doctor's office is actually getting us more response. So they recognize the phone number, they think it's the doctor, they feel a little bit more comfortable, they trust the number, and that has been giving us a little bit more success in kind of scheduling those care management calls. Some folks don't answer those either, and so we mail out a letter, say we've been trying to reach you. This is our nurse care manager's phone number. Please give us a call back. Those letters just went out this week, so I don't have any data to show that, if they were successful or not. But it is a work in progress, and even with the automatic phone calls, and hopefully when Chris comes up here, we can get some clarification. But what we're finding is that a lot of people, when they go to the ER and they're being admitted, they don't change their information. They just say, is all this correct? Anything changed? And they're like, nope, nothing's changed, but they might got new doctors. And so while they come up on CMS as having the Dr. X, Y, and Z, we're calling them that 3rd time. They're like, oh, I haven't seen that doctor in a year. So with the lag of delay, so we're trying to figure out the best balance to make sure that we're reaching out to the right patients and also getting them set up with care management. Any of you doing automatic phone calls for your episodic patients? Are you manually doing them at the office? Is it someone on your team that's doing it in particular, a nurse or? Okay.
I have someone from the ER, right? That's a calling. For the ER, yes. Your automatic calls, is that coming from your patient portal or is that through like a separate office?
It's a separate, so it's a system that's pulling from CRIS. So they're getting the report straight from CRIS. And as long as they have that their primary care doctor is one of ours, they're making that automatic phone call. Yes.
But so the automatic phone call is like a robocall,
Mm-hmm.
and then they press 1 if it is them.
Yep. And then the next question is, you just recently discharged. Are you feeling better, worse, the same? And then if they select better, they go to the next question. Do you have questions about your discharge summary? Yes or no? Do you need help following up with making an appointment? Yes or no. We're still looking at the data to see when people are hanging up, because those robocalls are, if you're thinking about the patients that we're dealing with, robocalls,
Document that you made the call.
we get a report every week about how many people they've reached, how many questions they've answered.
You get the answers?
Yes, we get the answers. And if there's a trigger, it goes straight to myself and the nurse care manager. And we call within maybe a couple hours to say, we heard that you needed a question answered about your discharge paperwork. So after the trigger, we get alerted immediately. Okay. Yes.
Well, how do you get that to then format into your score? I mean, if you get a telephone sheet, it doesn't really send it to, but you gotta get that to Chris or to the Maryland PCP to score you as to whether you have, and that's been my frustration. Is that we have a platform here that I have to type in, and I call the
Made the patient.
call the patient.
Yeah, it's a lot of data, a lot of
It's a
Excel
lot of data,
yeah,
And I got a 50% score when I do it 100% of the time.
right.
And that was a little frustrating, but I think that's where I disagree with the robocall.
Mhm.
There's a lot of communication that you can get from a patient talking to them.
Absolutely. And maybe coming from the doctor's office, I think
Yeah,
you
the
might
robocalls are
reach.
Very personal, and you don't think you get the information you're looking for.
Absolutely. So
I
really
can
cool.
also add to that, the whole idea of the robocall is something you want to consider when you're dealing with volume.
Mhm.
Because if you have about, say, 20 patients every day, both
Discharge.
ED and hospital, to have one person multiply 20 by 3 calls, of which is 40%, that now bumps it into day 2, that's 10 plus 20, that's 30, that bumps into Wednesday. So it just, you just have somebody who's
Yeah.
just doing this, and that's all that person's doing.
Right.
So if you think about the volume and you think about your workforce or the staff you have doing the work, the automated call is a triage. And if you remember the requirement, it says contact within 7 days or contact between 2 business days. It doesn't say solve the problem. So the fact that you've made the effort to contact is what we're trying to do, because we don't want you going 2-3 days before you say, oh, nobody even reached out. So a few things, like she said, I understand has been done, is first of all, the number is familiar. So they will choose a area code that's local. And
a
also
text message too.
and a text message as well. And then this is very scripted. So it's what the practice wants to be said. So hey, we're calling from Dr. A's office, and we know you've recently had a visit. So the fact that we're starting the conversation by saying we are calling from or on behalf of Dr. A's office breaks the ice. It's not just some random person. And then click 1 if you want. And like she said, if you stop by question 2, at least you responded. At least you said you had a recent office visit, and hey, you want to be contacted, or you have problem with your discharge. And that kind of in real time, the same day, the care coordinators get the information and they do follow up. But at least that initial, when I say heavy lift of outreaching has been taken care of. Now look at where it helps. Because the care coordinators are busy seeing patients who currently have active intervention plans for CHW, care plans for care managers, they're busy too. So if the triage helps them filter patients who actually picked up, I'm not calling them a patient that's unable to reach or the number is not working. So you're sure that 50%, 60% reach of patients who actually picked up. So I can do a follow-up. It's easier as opposed to.
I mean, I get a lot of information from my patients. My patients don't go to the ER for.
Anything.
Yeah, but they follow up to get more information. It's just the initial, it's just the.
It's not really enhancing care.
Yes and no.
Okay, I mean, that's.
I'm saying yes and no only because we're thinking about it in terms of volume, right? So delayed reach to the patient.
In the ER.
So that's what I'm saying, it depends on the volume of your practice. So that may be the best solution for the
I have
practice.
5, then I can make it 12, and I can manage 12.
Oh, you see, 12 is good.
And we try to educate the patients ahead of time saying this is coming, you will be receiving a phone call. So we have those posted in the office, and it's so new for us. The data is so minimum. We really won't know the success of it and if people really are. And then we found that the escalated, ironically, the escalated calls, when we call them and say, what can we help you with? They're like, oh, no, I'm fine. You know, I'm okay. Everything is fine. I've already made an appointment. So it's a reassurance type of thing. You know, we think that something is wrong because they indicated that, but then we call again to find out, and they appreciate the call, but it really was a mild, you know, I don't know why they said that they needed additional help. So, so for our long-term longitudinal care management, we are looking at trying to do home visits from the CHWs to reach those patients who we cannot reach over the phone. To just say, hey, we missed you. We're from your physician's office. Give us a call, whether that's a letter in their mailbox, or if we can do an assessment right then and there. We understand there's safety precautions when we have to do that, but we are trying to work that out as well. Anyone doing home visits now? You did? Okay.
And we have community, because I'm a care coordination specialist, and we also have community health workers too.
Okay.
So we kind of work hand in hand.
Okay. And at what point do you do a home visit? Do you confirm?
So if we need someone like eyes in the home with needs, what's
Mhm.
going on, then we would send a community health worker out. And usually like the lead care coordinators will send it to me first, and then if I feel like I am not getting enough information, we'll send out a community health worker to see, okay, do they have the actual medications?
Right.
Like, you know, what's going on outside of the house? Safety concerns, all that kind of stuff.
Right. You find out a lot when you go to the home. Okay. All right. Any other questions?
As a side note, I use my home health nurses. I've been building relationships with them for
Mhm.
eyes in home for extra eyes. I'm like, the patient is telling me this, but I really am not feeling like that's what's going on. So can you look at this when you go in on your next visit and make sure it is what they're saying it is?
And vice versa. I've done home visits where they needed home health and they didn't let the doctor know they needed home health. And so I said, well, would you consider having some PT at home? They're like, oh, yeah, I would like to get out this bed, out this wheelchair. So I think having eyes on both ends is really helpful as well.
And Sonia will talk more about how CHW help on the field as well in session 9.
Okay.
So
Is that it?
that's fast track. Is that it? I don't actually. Okay, so fast tracking again, care management assessment. That's a link there if you have the slide when you talked about having a comprehensive care management assessment tool. This is one that we recommend you look through and think about it. Excuse me. So the different subcategories in this assessment, I think it's like a 4 or 5 pager, is patient information, medical and physical health, mental health, substance use, housing and environment, social, transportation, educational, and vocational. So that way it pretty much sums up or covers every concern that the patient could possibly have. Again, develop a care plan after you've done the assessment. This is also a questionnaire quarterly report. So again, the AAFP tool can be used for this. This is one for managing patients with diabetes, depending on what level they are, and you can see the different recommendations for a care plan to come up with one. And this is evidence-based guidelines here, so be helpful to lean on that. Then document your care plan and follow up with the EMR. Again, going through a quick care plan. If the problem was medication management and compliance, you can set a care management goal where Ms. Anexa will receive her medication education and counseling in her next office visit. The intervention is that the practice pharmacist will meet with Ms. Anexa at her next office visit. Now, this is if you have a pharmacist co-located, or you can call in one for her. Ms. Anexa will need ongoing medication follow-up to ensure she's compliant with her medication, and this action is ongoing. So same thing, the second goal is a self-management goal. So she has her role to play here. So she will take her medication as prescribed every day for a week. Maybe we've identified medication adherence might be an issue here. The intervention here is that she will receive an electronic reminder medication appeal box. We're getting all innovative here. And then she will send a daily report to the care team. Ms. Anexa took her medication as prescribed for the week, goal complete. Now, notice this, we're trying to make sure we celebrate little successes. So the goal here was to try and, adhere to your medication just for 1 week. And when she is able to accomplish that, we check the box and say, hey, when can we do that now for 2 weeks? So things like that. So we already have discussed in a nutshell, LCM, ECM, but any other thing you wanted to share or questions you want to ask about care management and care plan to inform what you currently do? Yes.
What are you really talking about? Like you're saying education, are you saying like if the patient doesn't really understand their diabetes or their nutritional situation or something like that? Well, what are you talking about?
Yeah.
Their educational level, like they don't have high enough IQ to really understand anything that they're supposed to be doing. What are you getting at?
Is the previous rather than the latter. It's trying to say you understand that it is a condition that you have to play a role in managing. How can I educate you about the current behaviors that you're engaging in that helps or not? And sometimes you may think that saying it one time is enough. That's not true. So again, put it in on top of mind that you can have, diabetic groups, they have education for that, say, hey, or where are you? There are also have some programs that you have a buddy, that's somebody you can work with to see how they're trying to adhere to a diet or something like that. So that's what that speaks to. Any other question?
When you say you have an aligned evidence base, you said this is all evidence based. Where does that come from?
So that particular guideline is from the AAFP. Yeah, so lots of resources. We want to make sure that the sample, the examples that we give you, at least are things that have been tested and tried. That doesn't mean that you cannot become creative and innovate, but why reinvent the wheel when you can start from somewhere and then make it yours? Yeah. Okay. So we just talked about episodic care management already. So again, you can have different ways to do it, but once you have to meet a requirement, that's one thing, but see beyond what else is coming in terms of providing comprehensive care and following the patient from one healthcare setting to another. So 24/7 access, again, most of us already provide same day, next day, telephonic encounters, after hour services, direct messaging through patient portal, secure messaging, on-call scheduling, remote access to EMR. Again, that icon identifies if you're already doing this. When you report, always remember the patient's experience is that I was able to speak to a provider last week after office hours when I needed to, and that saved me a visit to the ED. So 24/7 access and alternative care visits, knowing your why. Why is this important? You can actually streamline communication between the care team and the patient and then save costs, reduce patient wait times, effectively meet your patient's needs and increase their satisfaction, potentially reduce ED visits and admissions, and improve preventive and chronic care with focus on self-management. Alternative care visits, I've already mentioned home visits, the group visits, telehealth visits, telephonic visits. Again, if you look at that icon, something you have to report up to. I know this is something that you would be reviewed on if you want to move from a track 1 to track 2. These are one of the things to keep in mind, that you do offer alternative care visits. So the focus of alternative care visits is to focus on preventive care and self-management, so you can help patients maintain and improve their health. So where we keep saying that we would like you to think about alternatives to traditional office visits, we're not asking you to replace that. We're just saying you should have traditional office visits when you need to, and then they don't have to in perpetuity be just 15 minutes, 20-minute slots. They can be more if you can have alternative visits to help complement that when needed. Okay, so this is a quick PDSA. If you wanted to set up group visits, to establish a diabetic group visit, to identify the practice, staff who will do it or conduct this. Most times this is delegated to the nurse. Identify the space you would have this done. Identify the staff training that's needed for this to facilitate the group. Choose the appropriate group structure and develop a structure and content of the session, and draft the group visit invitation, send out, invite the patients, do the group visit. And then study, what's the number of patients who attended? What's the variation between the planned versus actual time frame for the group visit? Did it take longer than planned? How can you adjust the agenda for next time? Any key issues that you noted with the group visit format that you need to make adjustments for? do another test of change to improve those, to make those adjustments, and then you can establish your group visits. So this is a small, I guess, a quick summary of the steps to conduct a group visit. Typically would take about 1.5 hours. So prior to the group visit, the nurse staff will typically spend 2 hours of prep time reviewing medical records and things and completing forms for that diagnostic testing and lab work. And then the group visit will happen. One thing I want to call your attention here is that if during the break, if the nurse completes a vital sign and the physician confers with each patient individually, they can still say, I have some additional health concerns to discuss with the physician. They could also do that in quick succession, and they can also bill for that visit as well. Again, you have to take it slow, start small, say maybe 5 patients in a group first to see how it goes, but something to think about. But you have to be willing to keep an open mind as to how you can leverage group visits to also have that as a physician provider encounter as well. You're done? Yes, go ahead.
What's the coding situation for that? Does each individual get their regular office visit?
So yeah, so I'll circle back with you on that. Yes, but it's true. They do happen. So maybe if you have, and that's why if you keep it small, you have 4 to 5 patients that can be done. There's a group that has 5, maybe 4 out of the 10 can actually have those extra follow-up depending on what's due for them. But yes. Okay, so we will not go ahead and do the poll, but just show of hands. How many? I guess let me rephrase this question. How many of us are still working on our longitudinal care management process? How many of us feel that we already kind of know what we're doing and we're good to go? Good. Okay, great. Great. So half and half. I want to say that it will take some tweaking as you go along, but it's nice to see that some of you here already have that all figured out. So experience with alternative visit types. How many of you currently offer?
Well, we're working on it.
Working on it, good.
We are starting with the group setting. We have a couple of support groups already launched for virtual care.
Okay.
But we're really growing that.
Anybody else that does any type of alternative care visits? Yes.
You're talking about like the video visit.
Video visits.
Things like that.
Things like that.
Visits we do.
Yep. Okay. So using data to plan care, know your why. It's important to use data that's available, at least through CRIS and your EMR, to develop your workflow and analytics. If it's not measured, it didn't happen. So please look at what the data is showing you and then apply your clinical judgments to administrative judgment, depending on who's looking at the data, to inform how you improve your processes. Track your ECQMs. You already know that this is 50% of your performance. So why don't you track that from now? And we have tried to work with practices to discuss it once again with the IT vendor and the EMR vendors to say, if we don't have these reports, can you configure that so that all the provider needs to do or the office manager needs to do is to push a button and they can just see how well they're performing in their ECQMs. So they have to configure the numerator, denominator, and whatnot, and all the data points for that. Okay, so in using data, we've already gone through the QI process. So just identify the crucial measures. What are you measuring? Where do you get the data for it? You have CRIS as a data resource for claims, and then you also have your internal practice system. So your EMR also has information that you cannot see in claims data. For example, your PFAC, and then access and continuing care coordination data points and interim ECQM measures. Then establishing an internal process to keep reviewing the measures and how your team is performing. I will skip this because we're just talking through how to plan care for your patient and patient population. And following this was another competition just to get your juices flowing. But I will just say that based on the video, the first question was, what did they begin with when the meeting started? And that was, they started with capturing the voice of the patient. So again, understanding the voice of the patient's voice or feedback. Was the extended care team involved? Yes, they were. What type of alternative visits were discussed? Home visits were discussed. What advanced care planning was discussed in the video? Yes, it was. And what is the best evidence-based tool to introduce a new care team? And it's a handoff. So that's the best way to say, hey, I'm your primary care provider, but this is your care coordinator. So I'm making the introduction, and having that one handoff helps to introduce the patients to the care team member. So as a recap, again, walking through the following requirements: LCM, care plans, referral management, episodic care management, follow-up to ED and hospital discharge, using data to improve care delivery, alternative care visits, using data to plan for care for your patient population, and then the patient's experience with care management services. So again, I put this here again so that you guys can remember it's a balancing act for care management between long-term and short-term. And then please take the post-survey questions for 18 through 22.